Hello, and welcome to the latest National Lipid Association Lipid Insights podcast. I'm your host, Dr. Peter H. Jones. Our topic today is actually going to focus on nutritional fads that clinicians may encounter during patient visits. And, some of our high-risk patients who may want to lose weight, for instance, and possibly improve metabolic risk factors, can get some interesting dietary advice from social media and various influencers. So I'm honored to have two registered dietitian nutritionists with us today, Anna Biggins and Lauren Williams, to discuss the popular diets and supplement fads that are out there and whether any of them are truly beneficial or maybe even harmful for some of our patients. So let me get our attendees to introduce themselves. Anna, you want to start first?
Yeah, thanks so much for having me on today. I'm Anna Biggins, a registered dietitian nutritionist with the Georgia Heart Institute. So I work for the Center of Cardiovascular Prevention, Metabolism, and Lipids, but I'm based in Kansas City. So I actually do all of my visits through telehealth for our patients. I specialize in heart health and lipid disorders.
Awesome. Lauren?
Yes, thank you for having me as well. I'm Lauren Williams. I am a registered dietitian nutritionist, and I actually specialize in pediatric. I'm in a pediatric lipid clinic, and I am currently at McLean Children's, which is a Baylor Scott and White medical center. And so we're seeing patients anywhere from 2 to 18 years and hoping to elicit changes for the whole family.
That is awesome. Well, that's wonderful. Okay, well, let's see if we can get started because I'm going to allow you guys to be the discussants of most of this information. But, maybe, Anna, you can sort of get started on what you sort of think some of the popular or fad diets that are out there that are maybe beneficial or not beneficial for our patients to be doing.
Yeah, so I would say the first thing that a lot of patients hear once they find out that they have high triglycerides is, weight loss can help. So get on a healthy diet, lose some weight, do some exercise, and then they'll go to Google and they'll find that a lot of different diets are out there. And I think a popular one these days is a carnivore diet. That's one that I keep running into in our clinic. And a carnivore diet is really characterized essentially by only eating animal products. And so that would include meats, poultry, eggs, seafood, shellfish, and different animal fats like lard, tallow, and butter. And with a carnivore diet, people may or may not have dairy products. They might have milk, or maybe they'll include yogurt, but usually it's a full fat version of those dairy products. And so, as part of the carnivore diet, it also excludes all plant-based foods. So they would not have any fruits, no vegetables, no whole grains, legumes, nuts, seeds, or plant-based oils. And so a carnivore diet can actually sometimes have an opposite effect on actually raising triglycerides and LDL cholesterol, especially. I know we're focusing just on the triglycerides today, but because of some of the saturated fats as part of that carnivore diet, it can raise triglycerides, unfortunately.
Lauren, what do you do with your pediatric patients? Do they ever come in on these kind of carnivore diets?
They do, and it's become a whole lot more popular over the last few years. The concerning thing to me is what Anna mentioned of we're eliminating a lot of fiber, and fiber is so important for a good, healthy gut and also regular bowel movements. So yes, we're focusing on triglycerides, and yes, weight loss can elicit decrease in triglycerides, but at the same time, you do have to preserve your overall health and well-being as well. And eliminating all fiber foods is not generally a good way to do that. And as an adjunct to the carnivore diet, I'm also still seeing a lot of ketogenic diets. So the ketogenic diet does have some of those fiber foods. So they might have vegetables, for example, but it's still a very low carb diet. And for anybody that might be listening that isn't aware, the National Lipid Association actually published a clinical perspective on the review of current evidence and clinical recommendations on the effects of low carb and very low carbohydrate, including the ketogenic diet. And it's definitely something that would be a really good read for anybody that wants more information into the science behind this, why it can be helpful or harmful to things like triglycerides or LDL cholesterol. But yes, we are seeing a lot of it.
Yeah, it's great you referenced that clinical perspective, because that was part of the nutritional interventions for adults with dyslipidemia in the Journal of Clinical Lipidology here recently. So that's something that's important. Um, you know, besides the ketogenic diet and possibly, interestingly, intermittent fasting, Anna, you have any interactions with patients who do those things?
I do, yes. This is a very popular one. It's been, yeah, kind of popular for the past 5 years or more, but kind of going along the lines with just that overall healthy lifestyle of people are trying to adopt something that's easy, something that's simple. And intermittent fasting, where you say, okay, I'm just going to have an eating window of so many hours, that can seem like a really simple fix for a lot of people. Then there is some research actually that intermittent fasting can improve certain cardiometabolic markers, right? Like it may improve insulin sensitivity. We have seen slight improvements with triglycerides and LDL cholesterol, but it is typically because of the overall calorie reduction. And I always like to kind of remind my patients, the human body is naturally programmed for some type of fasting, right? We're not supposed to be eating 24 hours a day because we do need at least 8 hours for sleep. So there is kind of that automatic programming that our body likes to have where we're fasting overnight. Um, but yeah, it definitely is popular, and I think it can work for some people, but it definitely is not the best approach for everyone.
Yeah, I would think not. Now, you know, so if a clinician gets a patient who says, "Yes, I'm doing the carnivore diet, or I'm doing the ketogenic diet, or I'm doing intermittent fasting," do you think they should say, "Don't do that," or "Wait a minute, I'm going to send you to a RDN. This isn't good"? I mean, how does a clinician interact with a patient that may be doing one of these kind of diets, and do it in a way that's somewhat respectful, but at least directing them to the proper thing? Anna?
Yeah, I think the best thing for a clinician to do would be curious. Ask your patient a question. Okay, why did you start doing this diet? Where did you find this information? What is your goal of this type of diet? Because that can uncover a lot of the reasons behind why they're doing what they're doing. And if they say, oh, it's because it's for weight loss, or it's to reduce inflammation, or if it's to reduce triglycerides, you could say, okay, I appreciate your interest and your concern of really prioritizing your health in this way. But I think there might be an expert who has some more details of how to do this in the healthiest way for you. Would you like a referral to a dietitian, right? Always asking their permission if you could refer out to a specialist in that area. What would you
Yeah,
say, Lauren?
yeah, Lauren.
I agree. I think finding the motivator behind the action is always the most important thing because, and also what Anna said too, of acknowledging that they are trying, they are putting an effort because these diets are not easy. Also asking them what that diet means to them, because if you look on social media, there might be some people that say that they're following a carnivore diet, but then I saw a post not too long ago that said, I'm a carnivore fruit diet. And so they're eating a carnivore diet plus fruit, which isn't necessarily the carnivore diet. So asking them what that means to them and the parameters that they're following. And then also I would add what has been their history. So a lot of the people that I interact with that have been on either a low carb or a very low carb diet, they have followed this style of eating in the past. We used to call it the Atkins diet, but a lot of people tried that, lost weight, gained it back, and so they're not going to try it again. And so now we're calling it a different version, which does have a lot of similarities, some differences, but a lot of similarities. It's still a low carb eating plan. I think it's also important, like Anna said, to take it back to what are their goals. I personally love to focus on lab values. I don't love focusing on weight because people can very easily develop disordered eating patterns and a bad relationship with food. And having a good relationship with food is actually the key to long-term changes, long-term health, because some of these can be very short-term, 2 to 3 months, and then we get tired of the diet type of changes. One thing to mention too, for the clinician to consider is that some of these diets, such as the ketogenic diet and the carnivore diet that are very high fat diets, can actually be very harmful for individuals with triglycerides over, say, 500. And so that high level of fat, depending on what the causation is for the very high triglyceride levels, but for those that are more responsive to fat, raising their triglyceride levels, increasing fat in the diet can actually increase triglycerides and put them at an increased risk for pancreatitis. So it's definitely something to consider, why they're doing it. Have they tried these things before? Acknowledging that they are trying, because that is very important. And that will help you to build rapport with the patient too, because you're acknowledging their efforts.
Yeah, well, there's also been reports that even some patients who do the ketogenic diet actually have elevations in their LDL cholesterol as well. And, whether that's due to the diet, again, the fats that they're ingesting or something that's making it worse, or, and again, compliance. Some patients think, well, I'm going on this diet, I don't need to take my statin now. And they stop taking their statin. You always have to make sure that if you see a change in their lipid values when you're checking them, that they're also not using the diet as an excuse to be non-compliant with their medications. So I think that's important. Do you find any, as you were talking about relationships with food? I mean, some patients may also want help with weight loss through GLP-1 receptor agonists. And do you find that it could be bad to do GLP-1 receptor agonists and these kind of fad diets as well?
I think it's important anytime that somebody's on a weight loss medication to acknowledge that nutrition is still a really important part. This medication isn't the end all be all in terms of making changes to their health. It does have to come in the context of making nutrition and lifestyle changes as well, and also fixing or preserving their relationship with food in the process. So a lot of individuals that are on these medications, they don't feel hungry, so they may or may not be skipping multiple meals. In pediatrics, ironically, intermittent fasting a lot of the time is often seen just because kids don't wake up early enough to eat breakfast before school, and then they skip lunch. And so they really only eat from 3 or 4 p.m. onward. And so if they are on a medication that's making them not hungry, then that might be exacerbated. They might have some nutrition deficiencies. Same with adults. If we're not taking the time out of our day to sit down and eat a meal because we're not feeling hungry, we're not getting all that our body needs. I don't specifically work with adults day in and day out, so Anna might actually have some really great insight into that too.
Yeah, absolutely. And I would say that the GLP-1 medications can certainly be a tool in the toolbox when it comes to people who have struggled with weight for their entire lives. But I don't think that it can replace a healthy lifestyle, especially when we're looking at the changes in body composition. With lean body mass, we know that there tends to be slightly more loss of lean body mass with these medications compared to other ways of losing weight. So really emphasizing getting enough protein and getting enough exercise and strength training is important. And then with some of the fad diets like the carnivore and the ketogenic diet, they're really high in fat. And we know that high fat diets tend to be a lot less tolerated with these medications. It might lead to more nausea, vomiting, diarrhea, constipation. Just a lot of the GI effects of these medications would be, kind of complicated by those types of high fat diets.
Yeah, well, I think clinicians are sort of encouraged by the outcomes data on a lot of the GLP-1 receptor agonists and the cardiovascular benefits and renal benefits and heart failure benefits. So they tend to think, well, maybe if they're obese, then this is a good way to help with your outcomes. But they don't necessarily then say, oh, and I want you to go talk to a registered dietitian nutritionist to help you with how to plan eating and how to do proper nutrition while you're taking this. Just don't prescribe the drug, right? And then just send them out the door and let them do whatever they're going to do with their food. So don't you think they should make sure that RDNs are an important part of the prescription of a GLP-1?
I think we're both a little bit biased in that answer. But yes, sir, we do. One thing I was going to mention too that's really important is kind of going back to what Anna said previously of being curious and talking to your patient, because it would be really easy for somebody a clinician to be speaking to one of their patients that comes in. You see they've lost weight, their A1C has improved, their triglycerides have improved, maybe their LDL has improved. It would be really easy to just say, you're doing an amazing job, keep going. But if in reality, really they're only eating snacks during the day, and then they might be eating one meal a day that's really not nutrient dense, or they've developed other disordered eating patterns. So what if they are binge eating sometimes, or they do have anorexia or some other type of disordered eating pattern? I feel it's very dangerous to only look at the labs and their weight and say, good job, keep going, without inquiring about their lifestyle choices, even if they don't have an RDN to see that is tracking those. So it's still important to ask them about what they're doing in terms of their nutrition and exercise, so that their long-term health is good.
Right. Yeah, I think that's very important. Let's move on to one of the other things that sometimes you'll find patients doing, if you inquire properly during the visit, is about supplements that patients may read about or hear about and think, oh, I'll do that. That's healthy. And maybe I don't need to take my statin or other drugs that you prescribe for me. So what about fad supplements in your mind? Anna, what do you think?
Yeah, I think this is a great point because even in my own visits with patients, I could say, okay, are you taking any supplements? And they'll maybe list a couple vitamins, but going a step deeper and say, okay, are you taking any powders? Are you taking any packets of things, right? There's so many different types of nutrition supplements in the market, but one of the big ones that I've been seeing lately is greens powders. There's lots of different brands of this, but basically just powdered vegetables, powdered fruits. And they're kind of freeze dried and then ground down into a powder that people can take in a capsule or like scoop out of a container. And we know that most Americans, only about 10% of Americans are not getting enough fruits and veggies on a daily basis. So when we think about that, it's like, okay, well, maybe these freeze dried things could actually help people get the fruits and veggies, but there's not that much research on them. So I don't feel super confident telling my patients, yeah, go ahead and use this as a replacement for fruits and veggies, because you're most likely going to be missing out, especially on the fiber, right? Like Lauren was mentioning before, we need to get these fibers from whole foods. And there's, like I said, not a whole lot of research on powdered greens. I was doing a little bit of searching before our podcast episode today, but I was looking at, are there actually any studies looking at powdered greens and outcomes, especially with the lipid profile and triglycerides? And I found one. It was a small study with only 10 participants, and found that there were some antioxidant benefits of taking a greens powder every single day for 4 weeks, but only a small amount of those antioxidants were actually detectable in the plasma after these people took them. So there could be some kind of issue with not actually absorbing what we think is beneficial from those types of powders, because when we look at the real whole foods that our bodies are designed to digest and metabolize, that's really where we're going to get the most benefits. But I do see some of those greens powders coming up, but I wouldn't necessarily recommend them.
Yeah, I think that certainly those kind of powdered fruits and vegetables don't contain the necessary fiber that's helpful for the GI tract and for helping the microbiome and so forth in the GI tract. So yeah, telling them that they can eat their fruits and vegetables in one little capsule is I don't think the kind of advice any of us would like to give our patients. Any other supplements that come to mind that you've heard about that sort of stir you a little bit into not being very happy? Either one of you? Anything? I know that, Lauren, you mentioned one of your family members had decided apple cider vinegar was a good thing.
There's apple cider vinegar is, I would say, becoming less common, I think, from what I'm hearing from people, but it still does come up. So there's not, I think the main thing to remember with all supplements is the fact that these things are not regulated. They are, the FDA is going to intervene if there's a problem. So if there is harm that comes from somebody taking this, I mean, people have literally died from taking supplements. And so I think that it's really important to make the comment of two things. One, you can't out supplement a poor diet. So if you're just relying on nutrition supplements and you're eating very nutrient poor foods every single day, you're probably not going to have really great overall health for the long haul. For my families that have kiddos that they're giving supplements to, I mean, there's greens powders for children now, which is a little concerning to me. But the way that it is marketed is if you have a picky eater, just give them this. And that's not true because you're not fixing the problem. You're band-aiding the problem. And so I think it's important to mention that these things are not regulated and you're kind of up to the whim of the company that's making it. So making sure that it is third-party tested. So there are companies that will come in and test a product to make sure that what the manufacturer is saying is actually true in terms of the dose and potency of these vitamins or supplements. And then, yes, so going back to your question of what are some of the other ones that we've seen, apple cider vinegar, which I do have some people that just drink apple cider vinegar, which makes me really concerned for their oral health, and their dentists probably don't like all of that acid on their teeth. Plus, it tastes terrible. Anything that you have to choke down every single day, no, thank you. And then also collagen's a really big one. And I think that that's for women, especially just for overall, hair, skin, nails, and all of that. It doesn't really have like the impact. I don't think people are taking it for their cardiovascular health, but it's a common one that we see. And then electrolyte drinks are another big one that, especially in the cardiovascular space, it can be concerning sometimes for those with high triglycerides. Electrolyte drinks that contain a lot of sugar and sodium can be harmful. Like, for example, if you have high blood pressure and you're drinking something with 1,000 milligrams of sodium one or more times a day, that's probably going to have a negative effect on your blood pressure. If you're drinking something with a lot of sugar in it and you have high triglycerides, that very well could raise your triglyceride levels. And so I think electrolyte drinks are another one that we're often seeing that isn't really necessarily a supplement, but it's something that people are incorporating into their overall diet. Anna, what do you see in terms of that space?
Yeah, 100%. I think that the high sugar sports drinks are definitely a detriment to high triglycerides. I actually had a patient a few weeks ago who was drinking 5 or 6 bottles of Gatorade, just regular Gatorade, every single day. She wasn't super active. I mean, she did some gardening outside, but it's not like she was working out 3 times a day and really needed to replenish those electrolytes. She just loved the taste of Gatorade. And I said, okay, are you open to making any changes with the Gatorade? Here are some options. We could cut down on the amount of Gatorade that you're drinking every day. We could swap out some of those for water, or we could maybe even try like a Gatorade Zero. Do any of those sound like something that would be doable for you? She goes, oh yeah, I could totally switch to Gatorade Zero. Let's do that. And then I'll drink some more water too. And so we rechecked her triglycerides in about 4 weeks of just changing the thing with the Gatorades, and they were down to a normal level. So the sugar definitely has a huge impact on triglyceride levels.
That's amazing. Well, one other supplement I want to bring up that patients can buy over the counter, thinking it's good for them, the omega-3 fatty acids. And I think that the question is, how do you deal with OTC omega-3s versus the physician saying, particularly if they're a higher risk patient with high triglycerides, going to prescription EPA? What do you do with that?
Yeah, so we know that omega-3 fatty acids are really helpful for triglycerides and just kind of that full body wellness aspect of we need to have the omega-3s. They're so essential for our bodies. But with the over-the-counter omega-3 supplements, usually you're getting a mix between EPA and DHA. And we have different goals when it comes to cardiovascular health for EPA and DHA. And we actually know that DHA in high amounts can accidentally raise LDL cholesterol. So Lauren and I were talking about that a little bit earlier, is that, some people may have these great intentions of starting an omega-3 supplement over the counter, but it accidentally raises their LDL cholesterol just unintentionally. But we do know that getting omega-3 fatty acids from fish and from marine sources can help lower triglycerides. And I don't know, Lauren, would you have any other suggestions on omega-3 supplements?
I think speaking to their clinician is incredibly important because, like you said, getting the omega-3s through the diet is what we want to see most often. If people don't like fish, then there are plant-based sources. So things like chia seeds, flax seeds, walnuts, all of those do have omega-3s in a different form. So it's a kind of a plant version of the omega-3s that you would see in fatty fish like salmon. But if they have been told by their clinician to take an omega-3 supplement for their cardiovascular health, I would encourage people to ask what outcome they're hoping for. So, for example, if all that you have is an elevated LDL, I wouldn't necessarily recommend going and getting the omega-3s because it can raise your LDL cholesterol. And I've seen that often in my own practice. But if it's for triglyceride lowering, prescription versions are going to be preferred because we know the dose that you're going to be getting versus, like I said, over-the-counter supplements are not regulated. And so we don't always know what we're getting. They could also have gone rancid, the omega-3s in supplements too, and then you're not really getting the benefit, and they could actually be harmful. Some of the capsules also contain saturated fatty acids. So prescription is preferred, but I do know that there are some insurance companies that will say there's a generic version of this, and so rather than prescribing this one version, why don't you do the generic? And the generic isn't over the counter. And I think that there are some generics that you can prescribe as well. But in my own experience, some people do have issues getting it covered for triglyceride lowering.
Yeah. Well, are there resources? I think the National Lipid Association has some resources for patients. I think some handouts about what to recommend dietary wise for patients, particularly if they have dyslipidemia like high triglycerides and have the metabolic complications of insulin resistance, obesity, and high triglycerides, and they're high risk for cardiovascular disease. And I think at learnyourlipids.com, I think is one of the places where you can get information for patients, and clinicians can find more data about some of this stuff at lipid.org. But I wanted to sort of boil this down a little bit here as we come near the end of our time. In particular, we're talking about fad diets and supplements. Okay, and particularly for patients at risk who may have dyslipidemia. If they're taking, many of them, if they're high enough risk, are probably on a statin, and so their LDL should be controlled if they'll stay compliant. But if they have hypertriglyceridemia, we know that triglyceride-rich lipoproteins are causative in atherosclerosis, and it's important to reduce that remnant cholesterol. What do you, as dietitians, recommend that patients limit in order to improve the presence of those triglyceride-rich lipoproteins? And then what should you prioritize in order to lower them? Lauren, you want to start?
Sure. So the things that we want to focus on is an overall balanced diet with lean proteins. So things like chicken breast, turkey breast, fish. Beans are a great source of protein. There are other plant-based proteins as well, like nuts and seeds. But lean proteins, complex carbohydrates, so carbs that are leaning more towards the whole grain category. So things like brown rice, whole wheat bread. You can do things like sweet potatoes and those types of things for carbs. And then also incorporating some fiber from veggies and fruits. Controlling fruit intake can be beneficial, so not going overboard with the fruits. I generally, in my own practice, recommend like 1 to 2 cups per day. But the reason for that is because the natural sugars in the fruits, if we're overdoing it, for some people can increase their triglyceride levels. But we want to focus on an overall balanced diet. And I will let Anna take what we want to limit or avoid as well.
Yeah, absolutely. 100% on that overall balance. And one of the things that I think is just so brilliant that we've shifted away from the food pyramid is now using my plate, or the plate method is what I like to call it. So trying to have half a plate of non-starchy veggies, a fourth a plate of those complex carbs that Lauren was mentioning. and then a fourth of a plate of lean protein. And that's a really easy way for everyone to visualize what a meal should look like. And I think it's great because you can have that visualization at home. You can have it at a buffet. You can have it at a potluck when you're at a restaurant. So many different ways to apply this. But kind of shifting into what I would recommend limiting or avoiding for our patients with high triglycerides. The first one would be alcohol. So no alcohol for patients, especially if it's above 500. If their triglycerides are above 500, then no alcohol, or at least limiting it to the very least no more than 1 drink per day for women and no more than 2 drinks per day for men, if it's kind of within that 150 to below 500 range. And that's one of the recommendations within the NLA clinical perspective on nutrition. The second one is limiting simple carbs and added sugars, especially from drinks. So like Lauren was mentioning, we don't want to overdo it on the fruits. The fructose within fruits actually raises triglycerides the most. Same thing, the fructose in drinks, whether that's coming from orange juice or high fructose corn syrup in a soda, we really want to limit the simple sugars. And then the third one would be to limit saturated fats. So this would be the types of fats that we're mainly getting from animal products, but also from coconut oil. That's one that could also even be a trend of cooking with coconut oil or adding coconut oil to coffee. I've heard of that one recently. So coconut oil is very high in the saturated fats that also raise triglycerides.
If I could interject too with that, a couple of things. One, with the sugar, there's a lot of people that misunderstand the discussion on sugar. Added sugars means any form of added sugar, not just the white table sugar. It also means agave, maple syrup, honey. All of these are forms of sugar that you can add to foods. And one thing that's really great about the newer version of the nutrition facts label that came out a few years ago is that it does list added sugars. So whenever people are looking at a nutrition facts label, take a look at the saturated fat, like Anna mentioned, take a look at the added sugars. And then also just overall things like protein and all of that based on your own health goals. But all of that can be really important, especially looking at those added sugars. And then also the saturated fats. There's a big push right now on social media about beef tallow and coconut oil, ghee. All of those are saturated fats, and they can raise your LDL cholesterol. For those with high triglycerides that are due to eating a high-fat diet. So I do have some people that respond to either one, eating too many calories for their body every day, and fats can contribute to calories. There's 9 calories per 1 gram of fat. And so watching overall the amount of fat, but trying to choose less of those saturated fats, but then also looking to, even if it's you have high triglycerides because your blood sugars are high or you have type 2 diabetes and your blood sugars are uncontrolled, going back to the ketogenic diet and the very low carb diets, we would not recommend going more towards the beef tallow and coconut oil and all those things that right now you're hearing are going to come in to save the day. We still want to do things like olive oil, avocado oil, avocados, chia seeds, flax seeds for our healthy fats.
That's awesome. Wow, we've had a marvelous discussion. This is awesome. What I'm hoping is that our listeners will appreciate how to talk to patients, as you mentioned before, to inquire about what they're doing and be curious, not be don't be mad at them because they're doing some of these things, but try to understand what they're trying to accomplish and then direct them towards an more appropriate way to manage their dietary intake to improve their cardiovascular status. And importantly, to make sure that RDNs are an important part of the clinician role in helping us take care of our patients appropriately. Listen, Lauren, Anna, I really appreciate you giving your expertise to us during this podcast. And I certainly hope that everybody who listened today stimulated them to spend some time with these discussions in their patient encounters for the next few weeks and months to come. I appreciate everybody's attendance today, and thank you all very much for listening.
Thanks so much.
Thank you.